All right. Can you introduce yourself for the tape?
Yeah, absolutely. My name is Dr. Taylor Walker. I'm a board certified family medicine physician. I'm also the national president of CIR SEIU, which is the nation's largest labor union of physicians. We represent 40,000 residents and fellows across the United States. And I am based in Washington, D.C. I'm here on the podcast because I fundamentally believe that physicians and all healthcare workers need to think of themselves. We need to think of ourselves as organizers. We need to think of ourselves as part of the larger labor movement so that we can stand in solidarity with the rest of the labor movement in our fight for justice and a more equitable system that really prioritizes and protects the health and wellness of all US citizens.
Well, I appreciate that. And thank you for joining us. And we're grateful to talk to you right here around Labor Day. You've talked about your work, and I want to step back because I don't think a lot of folks, unless they're in medicine, don't necessarily know what residents and fellows do. Can you tell us a little bit about the day to day of a resident and fellow and what kind of work it is?
Yeah, totally. So the joke that I say all the time is like, oh, you've seen Grey's Anatomy? Yeah, it's not anything like that. Um, but I think that's sort of the framework or the idea that people have in their heads about what a resident or what residency is. And things do get crazy, right? Like they do on Grey's Anatomy. But essentially, the reality is that we graduate from medical school as a doctor, as an MD, as a DO, and then we go into residency into our specialty of choice. So for me, I graduated from medical school and did residency in family medicine. You could do general surgery, internal medicine, whatever. And for a period of 3 to 7 years, depending on what specialty you choose, you are really the front lines of patient care in terms of the physician workforce. And so residents and fellows are working an average of 80 hours per week. That's averaged over 4 weeks. So realistically, you could work 120 hours one week, 60 hours the next, 80 the next, 100 the next, and that would be totally fine, right? That's 24/7, 365 days a year. Our schedules are made a year in advance. We always work holidays. We have very little control over our working conditions, over our schedules, over salaries, right? And we are really, like I said, the front lines of patient care. So if you have been admitted to the hospital, say, um, especially at an academic, hospital like the bigger hospitals you've heard of, the first doctor that you see is almost certainly a resident or a fellow. Um, and I think COVID, which I think we'll probably talk about a lot today, really shone a spotlight on the negative, sometimes dangerous, you know, impacts that being that frontline worker can have, right, on these young doctors at the beginning, of our careers.
hmm And one of the points that you often make is that too often physicians don't see themselves as traditional labor, and that it's critical for them to understand their role in this particular system.
Mhm.
Why do you think it's been so hard for doctors to self-identify as labor?
Yeah, I mean, for one, the landscape of medicine has just drastically changed in our lifetimes. I think just one generation of doctors before me like has a totally different concept of what it means to be a doctor. Because back in the 70s, 80s, 90s, private practices, physician group practices were huge. You had the opportunity to start a practice and build a practice with people um, who you enjoyed working with and who were values aligned, right? And you had a lot of autonomy to take care of your patients in the way that you're trained to take care of them in a way that is consistent with your values, right? And we have seen this enormous, um, just just huge expansion of corporatization of healthcare and privatization of healthcare. And I think, your work on in this area is really what it has been hugely inspiring for me, and you know, kind of got me into the whole into advocating for Medicare for all, because with this corporatization and privatization of healthcare comes more and more restrictions, less and less autonomy in terms of our ability as doctors to take care of our patients in a way that's values aligned and aligned with our training, right? And instead, we are forced to function in a system that consistently prioritizes profits over patients. And that is, I don't know, I have mixed feelings about the phrase moral injury, but like it causes a huge amount of moral injury for physicians working in this system today. And so I guess to kind of bring that back to the question of, okay, why labor? Like, why do we have to see ourselves as labor? The fact of the matter is that, at this point, 75%, 74% of physicians in the United States are employees of 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 a large company, a corporation or a for-profit company, and therefore we are laborers. We are very highly educated, very highly skilled members of the labor force, and we, with that, has come really a degradation of the autonomy that we have to take care of our patients. And so I think at this point, physicians have to think of themselves as laborers, as part of the broader labor movement. One, because we just are, and we have to accept that. And two, because the larger labor movement in the United States has always been the tool to protect middle class, to protect working conditions, right? To fight for justice and equity. And at the end of the day, that's what we as physicians are doing. We are fighting for
Hmm.
justice, for equity, and for wellness for our patients. But we also need to do that for ourselves,
Yeah.
And I don't know if you've heard this statistic, but it's something that has stuck with me for a really long time. And it's that doctors can treat roughly 15% of the things that bring someone into the clinic, right? So as a family medicine doctor who has always worked in the safety net, right? I'm often the first doctor that someone has seen in a really long time. And I end up talking about housing conditions, lack of transportation, right? Needing work accommodations. Um, and I say all the time, if my patients could just see a social worker before me, they wouldn't even need to see me. If I could just prescribe
Yeah.
somebody a house, that'd be it. And, you know, I can treat that 15%, but the rest of the labor movement can really, really help to address the rest of that 85%.
Yeah. And to your point, I think it's important for folks to understand that in the past, most physicians worked for a physician owned practice. And
Right.
usually what would happen is you would buy into the practice. You would work for a certain period of time employed by the practice, and then you would become a partner of the practice, much more similar to law firms. And
Mm-hmm.
then once you were a partner, you were a part owner of the company that you worked for.
Mm-hmm.
Today, that's not the case. Like we've had a McKinsey-fication of the healthcare system in a way that allows the corporate side of it, whether it's corporate hospitals that are buying each other up in ways that suppress worker power,
Mm-hmm.
or it's corporate insurance that is cutting sweetheart deals to collude with the hospitals. All of that has made it so that the vast majority of physicians no longer work for a physician owned uh, practice. And so instead of being management, doctors are now labor.
Yeah.
And I think the hard part about it is also that, doctors all, they saw themselves as special snowflakes. They got the best
Yeah.
grades and jumped through all the hoops. And I think that gets played against them. So
Mm-hmm.
I want to ask you, in the work that you do, physician organizing, there's this drop off between organizing residents and fellows to organizing attendings,
Mm-hmm.
right? And can you speak to a little bit about why you think that drop off exists and whether or not there's opportunity to potentially get folks who've joined resident unions to see themselves as labor past the time in which they're in the residency or fellowship?
Mm-hmm. Yeah, absolutely. So, you know, I have sort of begrudgingly joined the world of TikTok and social media because it's just simply how you reach the younger generation. Like, if I'm going to sit here and say physicians have to be organizers and we have to be laborers and we have to be politically involved in order to really take care of our patients and communities, like, regardless of how I feel about it, part of that is on social media, right? A big part of that's on social media these days. And so there's this thing going around on social media, basic on sort of medicine TikTok, asking like, are residents a vulnerable population, right? And there's a discourse about that, whatever. You can tell my TikTok algorithm is exceptionally specific these days. So, so there's this question of like, are residents a vulnerable population? And my answer to that would be absolutely yes, because residents do not have control over their working conditions, over their salary, over their schedules, over whether they're sleeping during the daytime or the nighttime, whatever. And we're the frontline workers, right? Like I've said. And so, you know, it is absolutely imperative for any worker in a vulnerable population or any member of a vulnerable population to find ways to advocate for themselves and to advocate for protections and just basic protections, right? And so I think that is really the driving force for residents being the first wave of physicians to unionize. But, you know, really just given everything that we've talked about, right? The erosion of physician-owned practices and this huge uptick in corporate and private companies buying medical practices and hospitals, attendings are increasingly finding, I'll say ourselves, because I'm an attending now, we are increasingly finding ourselves in this very similar position. And I think that there's this message that we're fed throughout medical training that like, just get to the next step, it gets better, right? It does get better, but like, it's a really different thing than
It still kind of sucks.
it still kind of
That's,
sucks. It
I
still
mean,
kind of
that's the
sucks.
hard
Yeah.
part about it, right? It's like, I think in the past it got way better, and it's interesting, right? Because there's this discourse between generations of doctors.
Yeah.
I remember being lectured at by this very well-meaning attending who was like, well, she trained in the 80s. She's like, you med students these days, and this would have been 2010s. You
Hmm.
med students these days want to have it easy, right? We used to stay back and just take care of our patients and do whatever our patients needed because, that's what our job is. And you
Hmm.
talk to some, older school uh, docs, particularly surgeons, and like that's the ethos, right?
Yeah.
And so they worked 80 hours a week forever and ever. The difference, though, is that they had a piece of what they built versus you work 80 hours a week for a large corporation who could cut you because you have zero job security.
Right.
And physician wages, not to say that physician wages are all anything low, there's nothing to complain about there, but
Right.
they've been suppressed, and more and more of the value that's created of a larger and
Hmm.
larger pie is going
Hmm.
to huge corporations that get to control and dictate what gets done.
Hmm.
And it's funny because I had sort of just been working on a project at that point, and I asked, I was like, you must have been a med student in the early 80s. She was like, yes. I was like, do you know how many medications were on the formulary in the early 80s?
I
She was
actually
like,
don't know the
no.
answer to
I
that.
was like, about 800. Do you know how many are on the formulary now? She was like, no. I was like, 10,000.
The limit does
So
not exist.
yeah, the we have more than 10x the complexity of what we do, right?
Absolutely.
And you had days and days with your patients because they used to be admitted, like the average admission time was like a week at least, right?
Yeah.
And now they're in and out. So it's interesting because you have this sort of rose-colored glasses about the good old days. And I'm like, well, the
Yeah.
good news is our patients actually leave,
Right.
right? In your
Yeah.
in your day, yeah, you killed a lot more patients than we did. That's a good thing,
Hmm.
right? But
Hmm.
it's a different practice, and the same cultural norms can't apply. It's like the same
Right.
thing as like getting lectured at by folks who went to med school in the time when most of their education was subsidized by a government in
Right.
ways they didn't realize about why we're complaining about student loans. You know what I mean?
Right.
It's just like, well, as a generation, our community has taken huge amounts of loans to be here,
Yeah.
right? In
Yeah.
ways that, that's the difference between ever buying a house and potentially not buying a house until you turn 50 on a physician salary, right?
Right. Hmm.
So like all that is to say, like there's just this cultural difference. And
Yeah.
it is a difficult thing in medicine because it's almost like you are taught to wear that work ethic on your sleeve,
Yeah.
right? And anytime you complain about doing a 24-hour, somebody's like, well, I used to do 2 36 hours a week. So, and you're
And you're
like,
like,
yeah, but like that was probably shitty and you probably killed a lot of patients doing that. Like
right,
that wasn't a good thing. Right.
right. Like,
Um,
yeah, how'd your patients do? Also,
yeah.
like,
Like,
how's your family? Right? Like, and it, yeah, I think it's also, I'm sort of like laughing because I'm in $440,000 of student loan debt.
geez.
And I went to a public medical school, you know, and I went without health insurance throughout my MD and PH, my 5 years in my dual degree program, because Tennessee didn't expand to Medicaid. And I went back to medical school and I was 26. I had the audacity of going back when I was 26. And I very realistically may never buy a house or be able to buy a house, right? I'm so fortunate to have a partner who did, right? Um, but left to my own devices, like that's just not in the cards for me. And so you talk to this older generation, um, of physicians, and it's like, yeah, med school didn't cost the same as it does for us. You didn't graduate with $300,000 of student loans. Also, like your housing costs were nothing compared to ours. I took out a personal loan my third year of residency just to be able to pay my rent because I did residency in Boston. And the cheapest apartment that I could find was like $3,200 a month, right? And that is completely different. And also it's way easier to like afford housing when you literally live in the hospital because you know that that's where the term
That's where the
resident came
resident comes from.
from, right? Like this is truly 1.5 generations of physicians ago. Like we were called residents because we were residents of the hospital. Like you live in the hospital. Like, I mean, one, that sounds terrible, but two, that's way cheaper, right? And so it is, I think, important for attending physicians to like find it in themselves to check the validity of their own perception, right? Like your perception of being a doctor is very, very different than the reality that the younger generation of doctors is facing. It is a totally different universe, right? I think the other piece of it, the other perception that really all of us in the professional managerial class like need to check is that like we need to sort of check our privilege and like check ourselves when it comes to how we think about the labor movement, right? Like when people think about the labor movement, they're like, oh, steel workers and electricians and, nurses maybe, but like not doctors, not engineers, not lawyers, right? And and actually I'll tell you a story that I'm I'm not super proud of, but I think is really important to know. So CIR, my union, the Committee of Interns and Residents, is called that. We are called the Committee of Interns and Residents because in 1957, when we were founded, the founding group of doctors didn't want to have numbers in the name. So you can think of like 1199 as a huge healthcare
Hmm.
union, right? When you think about like union names, you may hear like local blah 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 followed by some numbers. The founding members of CIR did not want numbers in the name because they didn't want to be associated with those people, right? Like
Hmm.
they didn't want, I guess put another way, like they didn't want their union name to sound too much like a union. And I think that highlights a really fundamental problem that is the result of our own biases and
Yeah.
perception that is actually damaging not just to ourselves and to our practice and our ability to like actually drive change, right? And build power and drive change in the face of these attacks on science and truth and innovation and whatever.
Yeah.
Um, but also like to take care of our communities because our perception of like not wanting to be associated with the rest of the labor movement just undermines our own power, right?